Hello everyone. Welcome to the part 2 of lecture on GCF. I'm Dr. Srashti Sharma. Let's continue. We have already covered introduction and history, formation, methods of collection. Now we are on functions. Functions of the GCF. Fine. Am I clear? Let's continue today's lecture. So, functions are to cleanse material from the surface. It contains plasma proteins which improve adhesion of epithelium to tissue. It has antimicrobial properties, antibody activity which defends the gingiva. It also acts as diagnostic or prognostic biomarker of the biological state of the periodontium in health and disease. So now composition. It has more than 40 components which are derived from either host or bacteria. Classification on classification. A. Cellular elements, bacteria, squamated epithelial cells and leukocytes. B. Electrolytes, which include potassium, sodium, and calcium. Then we can easily see the gingival plexus, junctional epithelium, oral circular epithelium, and we can easily see the bacterial plaque, which results in which increases the flow of GCF. So GCF has all the properties. With GCF has all the components of the adjacent structures. So now we are on cell type, that is bacteria, source, adjacent plaque mass, function, etiologic factors of periodontal disease, initiates the host immune response, epithelial cells, source, oral circular and junctional epithelium. It represents the high turnover rate of the epithelium that comprise the gingival sulcus, leukocytes, source, gingival plexus of blood vessels, function, effector cells of host response. Neutrophils play a role in innate immunity. Monocytes, macrophages, and lymphocytes play roles in cell-mediated immunity. Erythrocytes, source blood vessels, function, incidental fatting, results from damage to the small blood vessels and capillaries of gingival epithelium. Right? Then comes the organic compounds, carbohydrates, glucose, hexosamine, and hexavalonic acid. Glucose concentration is 3 to 4 times greater than serum. Proteins, IgG1 is more in number than IgG2 than IgG3, which is all equal to IgG4, IgGA, IgGM complements transferrin, albumin, fibrinogen, ceruloplasmin, haptoglobin, hemopexin, and beta lipoprotein. Metabolic and bacterial products like lactic acid, urea, hydroxyproline, endotoxin, hydrogen sulfide, antibacterial factors, cytotoxic substance like cytokines like interleukin 1 alpha and beta, interleukin 6, interleukin 8, thromboxane, TNF alpha, and PGE2. Now we will see enzymes and the other compounds. So enzymes, proteolytic, collagenase, MM8, 9, and 13, we see the source and the action. So sources are macrophages, neutrophils, fibroblasts, keratinocytes, and action is to degrade collagen. Cathepsin D, source lysosomal enzyme, nucleoleucocytes, action. It attacks various components of epithelium and connective tissue. Cysteine proteinases, cathepsin B, L, source macrophages, osteoblast, and fibroblast, primarily in intracellular degradation, also active extracellularly active during bone resorption. Then comes the serine proteinases, that is elastase, source eosinophilic granules of PMN. It activate upon elastin, proteoglycan, hemoglobin, fibrinogen, and collagen. Tryptase, source are mast cells. Cleave action, cleave third component of complement alternate pathway and can activate latent collagenase. Then comes the dipeptide dial peptidase 1 and 2 and 4. These are lysosomal enzymes. Source fibroblast, macrophages, T lymphocytes, and fibroblasts and macrophages. So the action is to cleave glycopropyl residues and play a role in collagen degradation. Cathepsin G sources are eosinophil granules of PMN. Action is to hydrolyze hemoglobin, fibrinogen, casein, collagen, and proteoglycans. Hydrolytic acid phosphatase, alkaline phosphatase, beta glucuronidase, and the lysozymes. It also includes hyaluronidase, protease inhibitors. So now we'll see the sources of acid phosphatase, neutrophils, desquamated epithelial cells, and macrophages. And the action is connective tissue catabolism, attacks teichoic acid, which is one of the component of bacterial cell wall, alkaline phosphatase, secondary granules of macrophages, endothelial cells, osteoclast, and fibroblast, role in calcification and bone metabolism. Beta glucuronidase and aryl sulfatase source eosinophil granules of macrophages, bacterial plaque, fibroblast, macrophages, and endothelial cells. Action as lysosomal markers, degradation of oligosaccharides. Lysozymes, source saliva, tears, nasal gastric and intestinal secretions, and the action will be bactericidal and fungicidal activity. Hyaluronidase, source lysosomal, and actions, widening of intercellular spaces in junctional epithelium, protease inhibitors, source inflammatory cells, action, it produces cystatins A, which is high in chronic periodontitis. Then comes the lactic dehydrogenase, source bacteria, dead dying periodontal tissue. Action is to catalyze the reversible reduction of pyruvate to lactate. Then AST, source tissue necrosis and cell death. AST levels are associated with active periodontal destruction. Cysteine endopeptidase, it includes gingivians. The source is P. gingivalis. Trypsin-like activity, stimulation of MMPs, activation of kallikrein pathway, cytokine degradation, deregulation of protein and fibronectin pathway, effect on complement components. So good predictors of future attachment loss are beta glucuronidase, MMP8, elastase, cathepsin D, dipeptidyl peptidase 2 and 4. Please remember this. This is very important. So now all the enzymes except acid phosphatase and lactoferrin, which are not associated with disease activity and severity, are positively correlated with severity of inflammation, protein depth, protein attachment level, bone loss, and level decreases significantly following the treatment. So now humoral immune response in GCF. So we will be comparing GCF with peripheral blood. So the amount of neutrophils in GCF, it is 95 to 97%, while in peripheral blood it is 60%. Monocytes in GCF it is 2 to 3%, while in peripheral blood it is 5 to 10%. Lymphocytes in GCF 1 to 2, in peripheral blood 20 to 30%. T cells 29% in GCF, while 50 to 75% in peripheral blood. B cells 71% in GCF, while 15 to 30% in peripheral blood. Then Gabriel et al., what he concluded is increased IgA levels in GCF from gingivitis sites when compared to that from periodontitis sites. IgA acts as a protective factor. Fine. So, Gabriel et al., what he concluded that IgA acts as a protective factor, which is present in GCF. It is the high levels are seen in the cases of gingivitis. Mononuclear cell infiltrate in lesions of periodontitis shows B cells and plasma cells. So predominantly IgG with lower number of IgA cells. So here we can see elevated GCF antibodies. It does not hold that much significance when you need to understand. So the percentage of GCF with elevated IgG antibody to AA, that is Actinomycetes Actinomycetium competens. So elevated GCF antibody and infection, we can completely see. This is in response to aggregative bacter Actinomycetium competens. So the complement in GCF is C3 and C4. Serum and maybe serum or locally produced. Healthy gingiva, 3% that of serum. Inflamed gingiva, 25%, 85% that of serum. Advanced periodontal lesion, larger proportion of B lymphocytes and IgG plasma cells that are reflected in IgG as the primary antibody component in GCF. IgA levels negatively correlated with attachment level, pocket depth, and bleeding. Sorry for the glitch. And bleeding before and after treatment. IgG levels, that is B cell stimulation in GCF from chronic periodontitis patient with active diseases. So now we would be studying gingival clavicular fluid flow. So, fluid flow is a rate measured. It creates a flushing action and isolation effect, determines the growth level of subgingival microorganisms, potential marker for periodontal disease activity. Definition: the process of fluid moving into and out of the gingival crevice or pocket. If it is a small stream, usually only a few microliter per hour. So, volume that crosses a defined boundary over a given time, mathematically symbolized as dV upon dt. So, three components of GCF flow: the resting volume, the influx, the efflux. Sorry. Sorry, there was some problem with the internet, I think. So we were discussing three components of GCF, the resting volume, the influx, and the efflux. So the resting volume is the result of forming a pool of fluid in the crevice or the pocket. So volume of any GCF sample collected divided by the time over which it was collected is the GCF flow rate. I repeat, volume of any GCF sample collected divided by the time over which it was collected is the GCF flow rate. This can only be true if the resting volume is zero, which appears never to be the case. These were the three components. So now uh, we will be studying this through an example, the leaky faucet problem. How does one measure the flow of water from a leaky faucet into a cup without removing the cup or changing the flow? Methods of measurement. Method 1, remove resting volume. Method 2, measure combined resting volume and influx of varying time periods. Method 3, measure the equilibrium concentration of a marker substance pumped into pocket at a constant rate. So, number 1, absorb the liquid. Number 2, measure the volume. And number 3, timing. So here we can see via mathematically method 1, method 2, a marker substance pumped into the reservoir at a constant rate will establish an equilibrium concentration dependent on the fluid flow rate. So here we can understand the flow rate, the delivery rate, pump, and the equilibrium concentration. Significance, GCF flow and experimental gingivitis. So, GCF sample volumes P1 and P2 during the development of experimental gingivitis, GCF flow and therapeutic response. So, distribution of GCF flow measurements of 68 sites in 17 subjects before treatment. T is equals to 0 and bars and 90 at 90 and 150 days following treatment. Values are ranged from 1.8 microliter per hour to 137 microliter per hour. So, nominal estimates of GCF flow and resting volume and effects on filling time of the pocket are devised. So, clinical characteristics, GCF flow, resting volume, and time to fill. In healthy device, GCF flow was 3 microliter per hour. Resting volume was 0.05 and time to fill in minutes was 1 minute. In intermediate pocket, GCF flow was 20, resting volume was 0.4, and time to fill was 1.2 minutes. Deep pockets, GCF flow was 44, resting volume was 1.5, and time to fill was 2 minutes. Shallow sulci in healthy subjects have GCF flow rates of 3 to 8 microliter per hour. Pockets with intermediate periodontal diseases have GCF flow rates of approximately 20 microliter per hour. GCF flow rates at sites with advanced periodontal diseases as high as 137 microliter per hour have been observed. So now this is very important. This also counts as a short note. GCF as diagnostic test or risk predictor for periodontal diseases. Easy and non-invasive collection. Dynamics and composition closely related to periodontal alignment can offer site-specific information. So these were the properties why GCF is considered as a diagnostic test or why GCF is considered as a risk predictor for periodontal disease. So now limitations of GCF as diagnostic medium. Lack of gold standard against which the test can be evaluated. Little information regarding attachment loss and bone loss. Methodology used for analysis of GCF components, fluorometry, metalloproteinase, enzyme-linked immunosorbent assay, that's ELISA. It analyzes enzyme levels and interleukin-1 beta. Radioimmunoassay, it analyzes cyclooxygenase derivatives and pro-collagen 3. High pressure liquid chromatography. It analyzes timidazole, direct and indirect immunodot test. They analyzes acute phase proteins. So now what are the commercial diagnostic test kits? They are available like PerioCheck. It detects natural proteinases, that is collagenase. Example is collected by a filter paper, paper strip placed in collagen gel, which is blue dye covalently bonded. Incubation time is 43 degrees Celsius. Neutral proteinases present in sample will attack the collagen gel and release the blue dye. Intensity of color is proportional to the amount of enzyme. Area of blue color is then scored on a scale of 0 to 2 by comparing it with 3 standards on a color card which is provided with the test set. Prognostic, that is Dentsply, it detects serine proteinases or elastases. Special paper strips impregnated with peptidyl derivative of 7-amino trifluoromethylcloberin, that is fluorescent living group. Substrate use is this one. It is developed by Enzyme System Products, which is in Dublin, California. If elastase is present in the sample, it reacts with the substrate in 4 to 8 minutes, releasing the fluorescent cleaving group, AFC. This produces green fluorescence in the strip, which can be viewed under UV light using a UV light box. Right? The intensity of the fluorescence is proportional to the amount of GCF in the sample and this is scored by comparing it with the AFC standards. So here we can see cysteine and serine proteinases. So what are the advantages? Accurate and simple to use. Color system more sensitive and convenient than fluorescence. Require no special apparatus in the clinical settings. Can be read after a short time. Can be shown to the patient and related to dose site. Sample collection on normal paper strips, so peptide substrate and leaving group are not introduced into the peptides and as in the Dentsply system. The assay buffer can be made selective for the enzyme in the question by making it in the correct pH. Now, what are the disadvantages? The choice of the most appropriate biomarker. Still, it is difficult at the present state of knowledge. Difficult in determining the sites to sample and when to sample them. If a moiety is associated with inflammation, this may mask its association with destructive disease. No account of biological control mechanism is taken in present test, and which is the one point which is very important and just the major drawback is cost. So now GSI test for AST is PerioGuard. It is the collection of GCF with filter paper strip placed in tromethamine hydrochloride buffer. A substrate is added to buffer and allowed to react for 10 minutes. In presence of AST, aspirate and glucarate catalyzed to oxalacetate and glutamate. Addition of dye that is phosphated. So color product intensity is proportional to AST activity in GSF sample. The problem is no detection of attachment loss. Then there is another GSI test kit for MMP8 by Mentila et al., which was given in 2003. Potential diagnostic use is an indicator of current disease status, possibility as a predictor of future disease, able to differentiate between gingivitis and periodontitis. So these are the graph levels. So now clinical significance. Presence of GCF in clinically normal sulcus is clinically normal. Gingiva exhibits inflammation microscopically. Inflammation means increased GCF. Mechanical stimulation, that is activities like chewing, vigorous gingival brushing, mastication of coarse food, gingival massage, intracircular placement of paper strips results in higher GCF production. Female sex hormones, when it increases the GCF flow. Like for the example situations like pregnancy, ovulation, and contraceptives, GCF flow increases during this time, and it also enhances vascular permeability. Circadian periodicity is gradual increase in GCF amount from 6 a.m. to 10 p.m. This is very important. Please remember it. Periodontal therapy, increase in GCF production during healing period after periodontal surgery. Smoking, immediate transient but marked increased GCF flow. Drugs and GCF. Bader and Galhalter in 1966 analyzed tetracyclines secreted through GCF in dogs, systemic antibiotics released from pocket wall, local drug delivery system, periochip, which contains fluorhexidine, esterase from GCF converts metronidazole into active substances. So this marks the end of our lecture, GCF part 2. Thank you so much and keep studying. Thank you.